Good afternoon, Sages. Thanks for having me. So, diverting lobe ileostomy is commonly created as a part of colorectal resection in order to reduce the risk of anastomotic leak and with better outcomes when compared to permanent colostomy. However, lobe ileostomy is not without consequences of its own and is associated with high rates of hospital readmission, most commonly for dehydration. In addition, these hospital readmissions for dehydration are also associated with serious consequences, including acute kidney injury and delayed adjuvant chemotherapy. We reviewed the literature for the risk factors and reducers for this complication, and the literature was limited to only single-center studies. Therefore, we aim to identify the risk factors and to create a prediction model for the hospital readmission for dehydration for patients who underwent diverting lobe ileostomy and to develop and to internally validate and externally validate our prediction model. After IRP approval, we obtained our development cohort from the ACS-NSQIP between 2012 to 2017. And by using ICD-9 and CPT codes, we could identify adult patients who were diagnosed with colon cancer, rectal cancer, benign neoplasm, IBD, or diverticulitis, and underwent diverting lobe ileostomy creation as a part of their surgical treatment. Our primary outcome was 30-day post-operative hospital readmission for dehydration that was defined by the ICD codes for any of the following: dehydration, lack of water, volume depletion disorder, acute kidney injury, acute kidney failure, and progressive renal insufficiency when the patient had no history of chronic kidney disease. We collected data for patient demographics, comorbidities, operative variables, and post-operative outcomes. The candidate variables were selected based on the statistical significance, the knowledge in the literature, and the clinical relevance. We had 11 candidate variables that were chosen, including age, sex, hypertension, diabetes, smoking, steroid use, elective surgery, length of stay, major mobility, and types of disease and procedure. For the model selection, each continuous variable was assessed by several function forms, and then the interaction terms were also assessed. Our final model was selected based on the highest AUC and was internally validated on bootstrap samples and assessed for calibration. For the external validation cohort, it was an independent group of patients that was derived from the nationwide readmission database between 2010 and 2016. We used the similar inclusion criteria by using the ICD-9 and ICD-10 codes for both diagnosis and procedures. For our development cohort from the ACS-NSQIP, from 25,000 patients, meeting our inclusion criteria, 530 patients were readmitted for dehydration, representing 2.2% of our population. Those patients were younger, smokers, with higher rates of severe ACA class, and they were more likely to have had diabetes, hypertension, and experienced major morbidity during their index admission. Patients were also more likely to have had been admitted for total colectomy with or without renal pouch construction for the treatment for ulcerative colitis or Crohn's disease with longer operative time. This is our model equation, and this model had an AUC of 0.74 with a good calibration by using the goodness of fit test. In internal validation, the model kept an AUC of 0.71. The external validation cohorts included 42,000 patients, where 2,700 patients were readmitted, and a random sample of 1,500 patients were used for the validation. Here we have all 11 candidate variables available in both datasets with reasonable similarity between patients in NSQIP and patients in RD. On external validation, the model had a reasonable AUC, which is 0.69. And here you can see an example for 4 patients who underwent diverting lobe ileostomy and to see their risk to get readmitted for dehydration. So we have patient 1 who is 55-year-old female who was admitted electively and had sigmoidectomy for the treatment for colon cancer and was diverted for technical reasons. This patient had no comorbidities and no complications, and her risk is less than 1%. For patient 2, a 60-year-old female who was admitted electively for proctostomy for the treatment for rectal cancer and had a hospital stay of 7 days with no comorbidities but some complications, and this patient had 2.5% risk of dehydration. For patient 3 is 60 years old male who had an emergency partial colorectomy for diverticulitis and stayed for 10 days and had multiple comorbidities and complications, and this patient had a risk of 9%. For patient 4, who is 65 years old male, and was admitted electively for total proctocolectomy with urinary pouch for ulcerative colitis and stayed for 2 weeks in the hospital and had multiple complications and comorbidities. This patient had a risk of 33%. Our study has a limitation. First, it's limited to its retrospective design and the ACS-NSQIP limitation to 30-day post-operative follow-up, the important data missing from some variables in the development cohort, and the administrative design of the validation dataset. In conclusion, we could identify the predictors for the hospital admission for dehydration in patients who underwent diverting lobe ileostomy, and we could create a prediction model that was internally and externally validated so that we can calculate patient risk for the hospital admission for dehydration, and that we can focus on high-risk group in the future initiatives. Thank you.